Good evening, my dear professors and friends. Thank you for holding with us for this late time for the third day in our conference. I would like to present Professor Muhammad Yassin for Survey Symposium. The platform is all yours, my dear friend, Dr. Muhammad Yassin.
Thank you. Good evening, ladies and gentlemen. Good evening, my dear professors and colleagues. First of all, I would like to thank Servier for inviting me to present the new data of managing of advanced and metastatic GEG cancer or gastroesophageal junction cancer. If we have or do we have option in third-line treatment? The molecular classification of gastric cancer according to the Cancer Genomic Atlas, we have 4 subtypes. We have chromosomal instability, which accounts for around 50%, which is characterized by intestinal histology, TP53 mutation, RTK RAS activation. And then we have for 9% EBV, PIK3CA mutation, VDL1 overexpression, EBV CMP, CDK N2 silencing, immune cell signaling. And for 22%, we have the MSI subtype, which is characterized by hypermutation, gastric CMP, MLH silencing, and mitotic pathway. And the most aggressive one is the gastric stability, which accounts for around 20% with diffuse histology, CDH1, RHOA mutation, Claudin 18 fusion, and cell adhesion. Stage diagnosing in Western countries, usually patients with gastric cancer are presented in advanced stage, and approximately 70% of all patients with newly diagnosed adenocarcinoma of the stomach and esophageal gastric junction become candidates for palliative chemotherapy. But overall survival with chemotherapy in advanced esophageal gastric cancer was poor prognosis. 2-year survival was 10 to 20%, median survival was less than 1 year, and chemotherapy prolongation of survival was from 4 to 11 months. Preservation and improvement of quality of life was the aim of treatment. Have we made any progress in the treatment of advanced gastric cancer? Here is the median overall survival comparison in advanced gastric cancer in several first-line treatment. And as we see here, the best overall survival was 13.8 months, according to the TOGA trial for trastuzumab plus cisplatin or 5-fluoroocabtagene. Have we made any progress in the treatment of advanced gastric cancer? Here is the risk reduction, death reduction in advanced gastric cancer as regarding overall survival. And as we see here, the hazard ratio is not significant for most of the active treatment used, with a hazard ratio or risk reduction of death of around 25% only. The standard of treatment of gastric cancer, first line fluoropyrimidines or plus platinum, plus or minus trastuzumab for HER2 positive patients. Second line paclitaxel plus ramucirumab or ramucirumab single agent, or irinotecan or docetaxel. And third line or later line, if irinotecan if not used in second line. And our new standard of care, or the only standard of care if we have used most of the treatment now, is trifluidine which is approved in the United States and Japan and Europe, and Nivo and Pembro if the CBUS score is more than 1. Selecting treatment for first-line therapy, key factors for optimal chemotherapy doublet selection, performance status, comorbidity, toxicity, patient preference for oral versus IV chemotherapy. Preferred options include doublets, preferred for lower toxicity, and triplets reserved for medically fit patients, FOLFOX-based therapies, and CABOX. Treatment for metastatic unresectable gastric cancer, active first line, based upon superiority trials, 5-fluoro, cisplatin, docetaxel, trastuzumab, based upon non-inferiority trials, oxaliplatin, which is non-inferior to cisplatin, and capecitabine S1, which are non-inferior to 5-fluoro, and irinotecan. HER2 overexpression is present in 6% to 30% of primary gastric tumor. First line recommendation, add trastuzumab to doublet chemotherapy for metastatic disease according to the TRUGA trial. Anti-HER2 therapy is not used in standard therapy in the second line because we lose the HER2 activity in second line and beyond. Use a guideline recommended regimen, example, ramucirumab paclitaxel for FOLFIRI for gastric cancer. Side effects to first line therapy may inform treatment selection. Here, if we have patients for first line, we have to measure for HER2 immunohistochemistry score 0. We give cisplatin plus 5-fluoro or plus or minus docetaxel or ibuprofen. And if our patient is immunohistochemistry score 3 from the start, the standard of care is cisplatin, fluoropyrimidine plus trastuzumab. But if immunohistochemistry is score is 2, we have to do FISH or FISH. And if it is negative, we treat it as score 0 or 1. And if it is positive, we treat it as positive and give cisplatin, fluoropyrimidine as trastuzumab. And according to progression, if the performance is still 0 to 1, we have the option second line paclitaxel or ramucirumab. If performance is 0 to 1 and need for remission plus or minus ramucirumab monotherapy or irinotecan monotherapy or taxane monotherapy. And if performance has deteriorated, we give active symptomatic control or best supportive care. So in the past, we were expecting only to treat patient gastric cancer, advanced gastric cancer, with a first-line therapy and a second-line therapy. And most of the patients didn't make it to third line. But with the recent positive trials in second line with the addition of ramucirumab either alone or to ramucirumab, we have some patients who could make it to receive third-line treatment. Metastatic gastric cancer recommended second line. We have ramucirumab paclitaxel based on the results of the Rainbow trial, ramucirumab single agent from Regal trial, Pembro if tumor is MSI high based on the Keynote 059 trial, docetaxel, paclitaxel, irinotecan. And here are the second line chemotherapy overview, irinotecan or docetaxel, ramucirumab alone or paclitaxel plus ramucirumab or paclitaxel versus irinotecan. Third line treatment option. All options available in second line treatment are also available in third line. Optimal selection depends on prior therapy and performance status. Ramucirumab monotherapy Regard trial include patients requiring second and third line treatment. TAGS trial demonstrated significant survival advantage for TAS 102, tibiracil, trifluidine versus placebo in third line treatment. Median overall survival was 5.7 versus 3.6 with a hazard ratio 0.69, which is better than the hazard ratio we have seen with many first line and second line trials. Median progression-free survival was 2 versus 1.8 for TAS versus placebo. Patients need to understand that the chance for disease response is low in the third line setting. TAS 102 is the preferred choice in third line treatment, considering IV versus oral chemotherapy, toxicity issue, ability to take an oral drug regimen in gastric cancer. Consider which agents a patient has already had. Consider quality of life, which is very important. Will there be a response to therapy? Which patient should receive immunotherapy? Yes, for MSI high tumor, situational for tumor MSS or underdetermined MSI status, and PDL1 CBS more or equal to 1, third line or later, and no for tumor with microsatellite stability or PDL1 CBS less than 1. Measuring PDL expression in gastric cancer, CBS assess PDL1 on tumor and nearby immune cells, and TBS assess PDL1 on tumor cells only. Pembro approved label and NCCN guidelines specify that PDL testing should be performed on CBS. Here are several trials in third line, apatinib, trifluidine TAG trial, avelumab versus investigator choice of chemotherapy, and Nivo, the attraction trial. So let's move to our recent approval or our approved third line option in locally or metastatic gastric G junction. Our trial is TAGS trial, in which trifluidine tibiracil was approved in EMA and Europe and FDA and Japan for third line treatment. As we all know the mechanism of action, trifluidine tibiracil is composed of trifluidine and tibiracil, which is responsible on inhibition of thymidine phosphorylase, preventing the degradation of trifluidine. And at the end, the result of mechanism of action, trifluidine tibiracil lead to DNA dysfunction and prevention of cell proliferation and anti-tumor activity. A very important message here that not all 5-fluoro-based regimens are the same, or not all fluoropyrimidines are the same. So it is very important. If we use IV 5-fluoro, for example, in the first line, we can use trifluidine tibiracil in third line because each of them has a different mode of action. And as we see here, figure 4 or S1 in Japan lead to DNA synthesis inhibition, while IV FU lead to mode of action is DNA damage, while capecitabine mode of action is RNA incorporation and RNA damage, while Lonsurf lead to DNA dysfunction. So the TAX trial, here is the randomization of the TAX trial. It is a multicentric randomized double-blind placebo-controlled trial with more than 500 patients. Remember, 500 patients is a large number in third-line gastric cancer. And patients are randomized 2-to-1 to test 102 plus best supportive care, 35 milligram twice daily, day 1 to 5 and 8 to 12, every 28 days versus placebo plus best supportive care with the same sequence. And the key inclusion criteria is performance status 0 to 1, more than 2 prior regimen, fluoropyrimidine, platinum, taxane, or irinotecan, HER2 inhibitor if available for HER2 positive disease, refractory or intolerant to the last prior therapy. Primary endpoint was overall survival. Secondary endpoint, progression-free survival, overall response rate, disease control rate, safety, tolerability. And the very important endpoint is time to performance status, deterioration, and quality of life. This study is well balanced between many countries in Europe, Asia, Russia, Belarus, USA, and Turkey. As we see here, in the past, the trials were done, most of the trials were done in Japan, in which the patient with gastric cancer have a better prognosis. Here, we use trifluridine in 17 countries from all over the world. So it represents the whole sector of patients around the world. Here are the baseline demographic and disease characteristics between trifluridine and placebo. As we see here, trifluridine significantly prolongs overall survival versus placebo, 31% reduction in the risk of death with trifluridine. At 12 months, 21% of trifluridine patients were alive versus 13% of placebo patients. Trifluridine significantly prolonged overall survival versus placebo, and in the subgroup of patients with GEG junction, trifluridine demonstrated an improved median overall survival versus placebo with a median overall survival of 4.8 versus 3.5. In the subgroup of patients with gastrectomy, trifluridine overall survival versus placebo was the median overall survival 6 months versus 3.4. Here are the forest plot overall survival benefits, which are all consistent across all patient subgroups and in favor of trifluridine. As regarding progression-free survival, 43% reduction in the risk of progression with trifluridine. At 2 months, 49.7% of trifluridine patients were progression-free survival versus 25.3% of placebo patients. At 6 months, the subgroup of patients with GEG junction, 15% of patients with trifluridine had no disease progression versus only 6% of patients on placebo. At 6 months as well, in the subgroup of patients with a gastrectomy, 13% of patients with trifluridine had no disease progression versus 3%. And trifluridine significantly increased disease control rate versus placebo. And this control rate was 44% for trifluridine versus 14% for placebo. And this is a very important issue that trifluridine prolonged time to ASU-ICOC deterioration compared to placebo, 31% reduction in the risk of deterioration of median to time to decrease performance status to over 2. And what is very important and significant, 74% of patients treated with trifluridine were still at performance status 0 to 1 at treatment discontinuation versus 63% with placebo, which means that after progression on trifluridine, we have a great subset of patients who can receive further line of treatments, which we didn't see before in metastatic or local advanced gastric carcinoma. Quality of life is largely maintained during treatment with trifluridine. And as we see here, time deterioration EORTC quality of life scoreboard by more than 10 points for trifluridine versus placebo, were all in favor trifluridine versus placebo, as we see here. At the end, here the dose is 35 milligram per meter squared twice daily without exceeding 80 milligram per dose. Tablets are available in 2 strengths, 15 milligram trifluridine, 6.4 milligram tiberacil, 20 milligram trifluridine, 8.19 milligram tiberacil tablet, to be taken with a glass of water within 1 hour after completion of morning and evening meals. And the dose is week 1 from day 1 to 5 with 1 hour after morning and evening meals and 2 days rest, and then from day 8 to 12 and then again 2 days rest, and the third week and fourth week is rest. As we all know, Lonsurf or trifluidine is a classic chemotherapy. So for sure, the toxicity is more hematological with a characteristic adverse events of neutropenia. Adverse reaction febrile neutropenia, as we said, recommended dose modification, interrupt dosing until toxicity resolves to grade 1 or baseline. CTCA, grade 4 neutropenia or thrombocytopenia that results in more than 1 week delay in start of next cycle. When resuming dosing, decrease the dose level by 5 milligram per meter square per dose from the previous dose level. For CTCA non-hematologic grade 3 or 4 grade adverse events, reaction except for grade 3 nausea or vomiting controlled by anti-emetic therapy or diarrhea responsive to anti-diarrheal medicinal products. Dose reduction are permitted to a minimum dose of 20 milligram per meter square per dose twice daily. Don't increase dose after it has been reduced. Here are the NCCN guidelines for first-line treatment, as we see, and for second-line and third-line subsequent treatment, we have category 1, trifluidine and tibrazil, and we have immunotherapy for MSI high or deficient mismatch repair tumor with a PDL expression by CBS more than 1. And at the end, I want to highlight a very important point, that trifluidine tibrazil is a new option for third-line treatment with a treatment which maintains quality of life and maintains disease control versus placebo. And in the future, we are waiting for new trials or combinations with trifluidine tibrazil, as we have seen in colorectal cancer. As we know that trifluidine tibrazil is approved in colorectal cancer in third line. And now we have many positive trials in combining trifluidine tibrazil plus anti-VEGF treatment BIVA with a very important trial in the first line treatment with a good preliminary results according to the phase 2 trial. So we are expecting that we in the future will explore trifluidine more in the context of metastatic and advanced GEG junction cancer, and I'm expecting many positive trials in second or first line treatment. And thank you for your attention, and I would like to thank Xavier for inviting me to give this symposium on the new indication of trifluidine tibrazil as a new option in third line treatment of GEG or metastatic advanced gastric cancer. Thank you for your attention.
Thank you, Professor Muhammad, for this elegant presentation, and thank you, Xavier team. And unfortunately, due to a shortage of time, we please submit your questions in the Q&A box and will be answered soon, inshallah. Thank you very much, everyone.
Thank you.